afternoon, everyone, and thank you for joining us for another edition of Fitterfly webinars. And we've been holding this webinar every month for the last almost a year now. And it's great to see so many people interested in joining us, even on a weekday, in a busy weekday, 3 to 4 p.m. So, welcome everyone. Today's topic is mastering insulin therapy in type 2 diabetes mellitus. We're doing it with Dr. Tejal. Dr. Tejal is an endocrinologist and practices in Navi Mumbai. A few of the places where she practices include, let me just tell you, one is Apollo Hospital at Belapur, Cloud9 at Vashi, and I believe her clinic's name is the Hormone and Bone Center, right, Dr. Tejal?
Yes, absolutely.
Where is it, ma'am? The Hormone and Bone Center in Navi Mumbai? Where
it's in Sector 14, Vashi.
Sector 14. So, welcome, Dr. Tejal. Looking forward to your presentation today.
So, good afternoon, everyone. Can I start, Neelesh?
Sure, ma'am. If you could just introduce the topic on what we're talking about, and then, yeah, you can definitely start your presentation, ma'am.
Sure. Just one sec. I'm extremely sorry.
We could see at the screen.
Yep, this should be good.
Yep.
Is that good?
That is.
Okay. So, good afternoon, everyone. And the thing is that because this talk is for doctors, I'm not really going to, like we have those usual talks where we talk about all the different insulins and which is better than which. And usually data is supplied to, support one or the other kind of insulin. But I feel that for clinical practice, that really doesn't help much. And what really helps is understanding how exactly practically how insulin therapy can be successfully initiated and continued in the clinic. I think that's what is most important, because when I was a young DM resident, there was very little I knew about insulin therapy. And what I'm talking today is probably just very practical stuff that helps me manage insulin therapy successfully most of the time in the clinic. So first, we'll briefly look at the traditional classification of diabetes and the new cluster classification which has come. I promise you I will not bore you with a lot of slides on randomized controlled trials. I will not include, in fact, any trial. I'll tell you what are the secrets to successful insulin therapy in my clinic. How you could encourage a different narrative around insulin for your patient. And then if you're doing all of that, then where is the problem? So traditionally, this is how we used to classify insulin, the pathophysiology of diabetes, right? That you have predominant insulin resistance or you have predominant insulin deficiency. So when you think of somebody who's predominantly insulin resistant, we think of somebody who's overweight, obese, has a sedentary lifestyle, eats a lot, has a lot of stress or sleep disturbances. Usually these people are well managed with medications early in the course of their disease and usually need insulin quite late in the diabetes journey. However, there is another type, which is predominantly insulin deficiency, usually lean people, a very strong family history of diabetes in multiple generations. They have usually long-standing diabetes, very high HbA1cs when they come to us, and usually is autoimmune in nature, GAD antibody positive, or type 1 diabetes. So this is what we were traditionally taught. Well, this is the result of a lot of hard work by a number of eminent diabetes researchers across the country. And this is how they've divided insulin type 2 diabetes in India. So one is, of course, the traditional one, which is 36%. That is mild age-related diabetes. And as people get older, they tend to have reduced pancreatic function, and therefore they tend to develop diabetes. And of course, you have the typical insulin deficient diabetes, where somebody who is lean, has low C-peptide levels, very high HbA1c levels, that is about 26%. So if you look at this, this is 35% plus 25%. So that's almost 60% of all the diabetes that we already see. These are the classic traditional ones that we were talking about. Then is the insulin-resistant obese diabetes, which again goes a little bit with the mild age-related diabetes, which also takes away the bigger chunk, which is 26%, typically high BMI, high C-peptide levels. This is the one, the 12% is something that usually ends up at the endocrinologist's door, because they've gone to multiple doctors, they've seen a lot of people, and somehow they're not able to figure it out. And these are people who have a combination of insulin resistance and insulin deficiency. So they're overweight, but not so overweight. They have a high waist circumference, but not as high as the classic insulin-resistant obese diabetes. They tend to have high triglycerides, low HDL levels, and are at a greater risk for retinopathy and diabetic kidney disease. But what is most important to understand is that they have a lower age at onset. So this is the one where traditionally we would like to give oral hypoglycemic agents, but actually they don't do well with oral hypoglycemic agents alone and require a combination of insulin sensitizers as well as insulin to get their diabetes under control. Now, what are the clues that when you see a person, you know that this is a person will need insulin therapy? So if I summarize this classification very simply, a much lower age at onset, lower BMI and lower waist circumference, lower C-peptide levels, very high HbA1c levels, and in spite of maybe 3 or more oral hypoglycemic agents, yet the blood sugars are not controlled. And all of this occurs relatively early in the course of diabetes. So these are the clues that you should look for when you are thinking of insulin therapy for a particular patient. Of course, there are extraordinary circumstances where a classic insulin-resistant obese diabetic can also need insulin when there's intense physical or mental stress and the demand for insulin totally outstrips the amount of insulin that the body is able to produce. And this usually happens in an inpatient setting. Somebody undergoes a heart attack, a stroke, an infection, severe dehydration, flu, or massive trauma. So these are extraordinary events where even in spite of being only insulin resistant and not really deficient, people end up needing insulin, often for a short period of time. Now let's come to the core topic today, which is the secret to successful insulin therapy. And I promise I did not try to make it very catchy, but it just fell into place that most important parts are selecting the right type of insulin, using the right technique, titrating the insulin, the timing of the insulin, testing for blood sugars, and tracking these blood sugars. So let's go through these one by one. So I think probably the single most important thing that you as a doctor can do is select the right type of insulin. So what happens is we all know this traditional thing about how blood sugars go up after each meal and we need a bolus of insulin before each meal. Then there's another kind of insulin secretion in the body, which is called as the basal insulin. The small quantities of insulin are secreted throughout the day in the body. And in an ideal world, classic insulin therapy would be the basal bolus therapy, where you give 1 shot of long acting and then you give 3 shots of short acting insulin to a person. We're also, as doctors, already all aware that there are a host of different insulins that are available. These are the rapid acting insulins, lispro, aspart, and glulisine, as well as fast acting aspart, who have the fastest onset of action, quick peak, and then a rapid decrease in the insulin levels, and the insulin is out of the body in about 4 to 5 hours. This is the traditional regular insulin. So both the insulin, lispro, aspart, glulisine, and regular are the bolus insulin, which we give with food. Regular insulin has a slower onset of action. The peak comes much later, about 3.5 hours, and stays in the body for even up to 12 hours. As is intuitive, that the problem with regular insulins, if you really want it to coincide with the peak of food, you'll need to give it much before the food so that the onset of action mimics the actual blood sugar rise in the body. And because it has a delayed fall off, it can lead to hypoglycemia as well. These remaining 3 are the traditional basal acting insulin, NPH, which we don't use much except maybe in pregnancy, detamir, which is not really a true basal because it needs to be given twice, but we're all aware of glargine, the U100 as well as the U300, as well as degludec, which are true basal insulins, which can be given only once a day. I'm not going to go into the pre-mixed insulins because I think all of us are familiar with, but this is the basic principle of insulin therapy that we would like in an ideal world. These are most of the insulins that are available. Now, how do you decide which is the type of basal insulin that you would use? Now, if a person has a predominantly high fasting blood sugar, then basal insulin is the one that you would like to prescribe. If there's a predominantly postprandial blood sugar which is high, then you would choose a bolus insulin. If both the fasting and the post meal are high, then yes, in an ideal setting, we would like a basal bolus insulin, but most of the time pre-mixed insulin is used, which has the convenience of being used twice a day. Please remember that when we say pre-mixed insulin, 99% of the time, we're talking about the 30-70 insulin, which is 30% short-acting and 70% long-acting. In exceptional circumstances, when the fasting blood sugar is high, but the postprandial blood sugar is even higher, in this case, a 50-50 insulin, which has an equal concentration of short and long-acting insulin, can be considered. Now, this sounds very confusing. So let's take a couple of examples to understand a bit more in detail. So for example, you have a person who has about 10 years of diabetes, has already on multiple oral hypoglycemic agents, obviously has osmotic symptoms where the blood sugars are very high, or has some diabetes related complications like retinopathy, neuropathy, and you know that you really need to get the blood sugars down for this person. The HbA1c is 9%, but if you look at the fasting and the post meal, the person's day starts with a really high fasting blood glucose, and then the post meal blood glucose is not much higher. It just increases by about 20 points. Now, in this situation, the very fact that you can bring this fasting blood sugar down, say from 230 to 130, most probably you will be able to bring down the post meal as well from 250 to 150. So in this particular patient, if he or she is sitting in front of you, if you see this person, a basal insulin once a day, long acting would be a good choice for this person. Now let's look at a different example. So somebody has very long-standing diabetes. They have chronic kidney disease, the creatinine is 2 or 3, or they have liver failure. And typically in both renal and liver failure, what happens because there is no gluconeogenesis or gluconeogenesis is limited, the fasting blood sugars are usually normal. So you would get fasting as low as 90 to 100, but the post-meal blood sugars are disproportionately high. So fasting is 100, but the post-meal blood sugar is shot up by about 150 to 175 points. Also, these people are at a very high risk of hypoglycemia. The reason being, again, because they have limited gluconeogenesis. The glycogen reserves of the liver are depleted, and therefore we have to be very careful, and we preferably would avoid basal insulin, which can be ultra long acting and can cause fasting hypoglycemia. And this person would be a very good target for a very good candidate for bolus insulin. So normal fasting blood glucose, but disproportionately high bolus post-meal blood sugars, irrespective of the HbA1c. In somebody who already has renal and liver failure, you want to conserve whatever liver or renal function they have, then a bolus insulin is a very good choice for this person. Let's look at a third example now. So we looked at someone who has a predominantly high fasting blood glucose. We looked at somebody who has predominantly a post-meal high blood glucose. Now let's look at this person who also has long-standing diabetes, has osmotic symptoms, has severe muscle loss and fatigue, which is very common in long-standing diabetes with very high blood sugar levels. These are diabetes-related complications are already there, retinopathy, neuropathy. The HbA1c is 11%, and the fasting and the post-meal are both very, very high. Now, in this person, starting with the basal insulin, then gradually getting the fasting blood glucose down, then attending to the post-meal blood sugar will take a long period of time and will not give quick symptomatic relief. So this is somebody who requires both the basal coverage as well as a bolus coverage. Now, for a general practitioner or a physician, it's often difficult to convince people directly of the need for basal bolus therapy. That's 4 injections a day. So at the level of a general practitioner or a physician or even an endocrinologist where the patient is absolutely not willing for multiple shots of insulin, a premixed insulin, which is probably 30-70 in combination, would be a great choice for this person. This, because you're providing both basal and bolus, there will be rapid drop in blood sugars. The HbA1c will come down faster. The weight loss will be ameliorated. The fatigue will be better. The muscle will start getting, the muscle loss will stop. And this person will get a sense of well-being much, much faster. So in this person with a very high HbA1c, very high fasting as well as post-meal, a basal bolus therapy or probably even a pre-mix 30-70 twice a day would be a good idea. So I'll also take the questions along with, the thing, because it always makes it more relevant. So yes, instead of 4 injections, Rhizodec, the thing is we prefer not to talk about specific brand names. So when I say premixed insulin, I mean any kind of premixed insulin. It could be, the rapid acting ones, it could be the regular ones, or it could be the co-formulation. All three of them will work, right? So thank you for that question, Dr. Mulchandani. The next example that I have is somebody who has 10 to 12 years of diabetes, and this is a very common scenario in the clinic. They need fitness for surgery, so that's the time they remember the doctor. And it's a major surgery. It's under general anesthesia. The HbA1c is 9%, and this person has a fasting of 170 and a post meal of 360. Now, in this case, for quick results, I would, and also somebody who's never taken insulin therapy before, a premixed insulin would not be a bad choice. But the reason I specifically put this particular example is, if you can see, the fasting blood sugar is not very high, but the post-meal blood sugar is really, really high, and it's almost double that of the fasting blood sugar. So in this particular situation, if I use a 30/70 insulin, what will happen is, because I'm giving a lot of basal, not that much of short acting, the fasting blood sugar will come down very quickly, but the post meal will not come down as much as we want. So you need just 40 points drop to come to a normal fasting blood sugar. But if you drop the post meal by just 40 points, it won't be of much use. So in this particular situation, using a 50/50 insulin, where there's 50% of basal and 50% of bolus, will lead to a much better post glycemic control, will also lead to a more rapid control of blood sugars, and you will be able to give the patient a fitness for surgery maybe in about 4 weeks maximum. A 1% drop of HbA1c can be achieved. The last example, of course, is a no-brainer. Pregnant lady, 28 weeks of pregnancy, her OGTT is positive, and when the gynecologist asked her to check her sugars, we found that the fasting is normal, but the post meals are high. As we all know that in pregnancy, the post-meal target is 120, and this woman already has a post-meal of 145, 155. It's already 28 weeks of pregnancy. She's already taking 4 tablets of metformin. There's not really any room for increase in the metformin. In this particular situation, bolus insulin alone would probably be sufficient for this woman, and giving 1 shot of a bolus insulin before each meal, that's 3 times a day, would probably be the best choice. This is absolutely somebody in whom you must not consider a basal, and you must not use a premixed. The reason being that premixed, especially the 30/70, can actually be quite dangerous. It will not only it will cause the fasting to go very, very low, it may not be able to bring the post meal down. So not only will you not be able to control the post meal, you'll go to dangerously low fasting blood sugar levels, and you may actually cause bad hypoglycemia. So before I close this particular section of type of insulin, whenever you are starting insulin and you put the pen to paper, take a second to just stop, to look at the HbA1c, look at the disproportionate fasting and post meal, look at the person, look how obese they are, look at their age, how well they would take to 4 injections. Would they be more comfortable with 2 injections? What about their insulin technique? Are they dependent on somebody else to give them insulin? All of these things need to be taken into consideration before deciding the insulin. One last thing that I would like to say, that because premixed insulin is a very, very popular insulin, but unfortunately, it's also the one which causes large swings in blood glucose. So premixed insulin is usually a good choice for a person who eats meals at a regular time and doesn't miss or skip meals. Is also a good insulin for those people who have a relatively consistent carbohydrate consumption. In somebody whose carbohydrate consumption from meal to meal or from day to day varies greatly, the premixed insulin will cause a lot of mismatch between the dose you give and the blood sugar desired, and usually will not give you good control. What will also happen is, if you give insulin and the person doesn't do well, it also reduces the faith that people have in insulin, and often you will find them remarking, you know what, मैं तो insulin भी लेता हूँ लेकिन मेरा sugar तो 300 से कभी कम ही नहीं आता है. So this is very, very important. Now, doctors are usually good at their part, which is the pharmacokinetics, pharmacodynamics, and the type of insulin. But probably where we take a hit is the technique of insulin injection. And what I would like all of you to remember is that The technique of giving the insulin is very, very important. And as this picture shows, that the fastest insulin absorption rate is from the stomach. But of course, we all know that we leave 4 fingers around the navel in a circular manner, and then you can give the insulin around that. The second best absorption is basically on the lateral side of the thighs. And then, of course, is the hands and the buttocks, which we are not very keen on giving because it's also very cumbersome. Second is most important is taking this pinch of fat and then injecting the insulin, counting till 10 to 20 after the injection is over, and then gently removing the pen. These two things are extremely important, and it's really a good idea if you could have access to a diabetes educator who could train people on how the insulin is to be given. Yes, Dr. Mulchandani, 30/70 can be given twice daily in different doses. But if you really look at the blood sugar profile properly, then what you will realize is that with the 30/70 2 times a day, I know everybody is very fond of 30/70 and it's like their pet, yeah, whatever. But with 30/70, usually if you look very closely at the glycemic profile, the post-lunch sugars will be high, and fasting will be pretty much okay. There may be low sugars at about 4 o'clock in the night, and there could be a post-dinner hyperglycemia, again a 3 a.m. hypoglycemia. So I'm not against premixed insulin therapy, but it requires a lot of monitoring. It requires proper titration. Just giving 2 shots a day and doing an HbA1c at the end of 3 months does not serve our patients well. But again, thank you for the question, and at least I know somebody's listening to my talk. So of course, technique is very, very important. A practical demonstration in the clinic, if possible, is great. A lot of insulin companies provide that support where they send somebody over and the diabetes educator teaches them. But what you have to remember is you also need to cross-check what the diabetes educator is teaching them. So many times it has happened that just recently, the patient could not come to the clinic. So I requested somebody to go over at home to teach them about basal insulin. And what the person told them is that after basal insulin, you have to eat something and go to bed, which is actually an incorrect instruction. And after taking basal insulin, you don't really need to eat anything. So it's also important to cross-check what these diabetes educators are telling your patient. The next thing that we have to remember is why the technique is important. So this is a case what came to me. I will never forget this boy. So he is 10 years old. He was seeing a pediatrician for his diabetes, and he was getting admitted recurrently to the hospital, maybe once every week, for diabetic ketoacidosis. And the doctor used to keep asking the patient, are you missing insulin? Are you missing insulin? And the parents would say, no, we're not missing any of the insulin doses. And actually what was happening, though the picture is not representative of the 10-year-old boy, but what the child had was lipohypertrophy. So what was happening is that the parents were injecting the insulin on both sides of the umbilicus only every single day. There were these 2 large lumps on both sides of the navel. And what used to happen is the day that the insulin was injected into the lump, the insulin would not be absorbed in the body. The baby would go into diabetic ketoacidosis. The day the insulin was injected in a site away from that lipohypertrophic region, it was actually absorbed, but it was a very high dose because we had been trying to compensate for the decay, and the child would then go into dramatic hypoglycemia. So lipohypertrophy, just lifting up the shirt, lifting up the sari and seeing the stomach area where they're injecting the insulin, palpating along the thighs is very, very important. And lipohypertrophy can be avoided by rotation. That is, the patient takes the insulin at a different site every single day to prevent the same skin being injected again and again, and to avoid lipohypertrophy and atrophy. Now, according to me, this titration of insulin. So you may be a great doctor. You selected the right type of insulin. Your diabetes educator did a great job and gave the insulin technique correctly. But the best insulin in the world is of no use if you don't titrate it correctly. So I will never forget this man. He comes to me. I remember he was at MGM Hospital. He said, you know what, he was on oral hypoglycemic agents. And I said, you know what, if you take insulin, your sugars will get controlled. He said, you know what, doctor, please don't tell me about insulin. I have tried insulin. It doesn't work for me. My body is immune to insulin. I have taken insulin for 3 months and my HbA1c was still the same. Now what had happened is the doctor told him, आप इंसुलिन शुरू करो 10 यूनिट लो और शुगर अगर ऊपर नीचे होती है तो इंसुलिन थोड़ा ऊपर नीचे करना. That was the depth of the information that he received at the time of the insulin initiation. So what this gentleman did is he took 10 units of insulin religiously, but he took it alternate days and just randomly decreased the doses depending upon what he ate for dinner. So if he ate a heavy meal, he took more insulin. If he ate a light meal, he took less insulin. This is glargine, a basal insulin, and he just took it alternate day. And obviously at the end of 3 months, his blood sugars were not better and he stopped the insulin thinking it doesn't work for him. So what is most important in titration is to know how frequently to titrate, which sugar to test depending on which insulin you're using, what is the target you need to achieve, and how much to decrease the doses. This is very, very important. So frequency usually depends upon the person. Very high blood sugars, you would check more frequently. Not very high blood sugars, you would check less frequently. But usually if a patient is only on basal insulin, then checking one fasting blood sugar every 2 to 3 days is a good idea. To adjust your basal insulin, that is glargine, degludec, you need to titrate the fasting blood sugar, not the post-dinner blood sugars. If you're using bolus insulin, then you have to titrate according to the post-meal blood sugars. And if you're using a premixed, again, this becomes a very tricky affair. You have to check the fasting, the post-breakfast, the pre-dinner, and also keep a track of the post-dinner. So the most difficult part about premixed is the easiest insulin to initiate and convince people of. The most difficult part about premixed insulin is titration of the insulin. The target that you want the patient to keep depends upon, if it's a young, healthy person, then you would go for a strict target, maybe fasting of 90 to 130. If it's an older person, multiple comorbidities, short longevity, you would like to keep a more relaxed target. Also, if you're starting with very high blood sugar levels, you want to keep a more relaxed target in the beginning, and then you can tighten the target after the HbA1c comes down. So suppose somebody starts with a fasting of 300, then don't aim for a fasting of 100. Even a fasting of about 150 would be a good target for this person. How much to increase or decrease the dose? So I just took a picture. I mean, usually my patients send this to me on WhatsApp. So this is how I share with my patients. Dr. Kaushik, the reason why I specifically did not include the discussion of insulin pumps in today's talk is because let's first master just the basic insulin therapy. Because as an endocrinologist, every single day when people come to me, even with just the basic of insulin therapy, most of what I'm talking about is not done. And in spite of insulin, people are not at goal. So Dr. Neelesh did say that, will you be talking about insulin pumps? Then my answer is no. But I would also like to tell you this, that even an insulin pump in the hands of a person who is not educated about its use, who does not understand the meaning of basal and bolus, does not understand the meaning of nutritional correction, does not understand the timing of the insulin therapy, even an insulin pump is a very expensive way of finding out that you can't control the blood sugar. So I have patients who are on pump. I have a doctor right now who's on a pump, who in spite of using the pump, his HbA1c is 10%. So I'm sorry, but today I will not be talking about insulin pumps. So this is a simple note that I write on my patient's paper. So I'm sorry for the company names that I'm using, but this is an ultra long acting insulin, and basal insulin has to be titrated against the fasting. So I tell the patient that if suppose we're starting with a blood sugar of 200, I'm starting you on 10 units of Tresiba. Now, if you do the blood sugar after about 3 to 4 days and your fasting blood sugar is still more than 180, I would like you to increase the dose by 4 units. So suppose his blood sugar was 200, I gave him 10 units of insulin, it came down to 190. I would go to 14 units. I would give him 14 units for another 3-4 nights. I would ask him to check his fasting blood sugar again. This time, suppose it comes to 150. Then I would go up by about 2 units. So that would be 14 plus 2, 16. Now, suppose with 16 units of degludec after 3 to 4 days, I check the fasting blood sugar and it comes to 110. So that means this is the target has been achieved. It's between 100 and 130, and I stick with 16 units of insulin. As is often the case with continuing insulin therapy, the blood sugars do tend to drop. So I instruct my patient that if you keep checking the fasting blood sugar at least once or twice a week, if it say drops below 100, I'd like you to reduce it by 2 units. And if it drops below 70, I'd like you to reduce it by 4 units. So patient needs to have all of this instruction in place so that even when they're at home and they're checking their blood sugars, they're empowered to adjust the insulin on their own. Similarly, for the short-acting insulin, I instruct them that if your post-meal blood sugar is more than 180 with say 10 units of insulin, you need to increase it by 2 units. And if it drops to below 140, you can reduce to less than by 2 units. So this is of course very simple. In the first few weeks, we provide WhatsApp support to all our patients because it's difficult, and especially if somebody is not very well educated, it is difficult to titrate insulin. But I think that as a doctor, for successful insulin therapy, we cannot have successful insulin therapy if we do not titrate the insulin. Dr. Kaushik, I'm extremely sorry, but I will not be talking about insulin pumps today, as I already said. So this is a video which I have, and I just wanted to show. I made this video and I put it online, and this is something I made. So this you can just share with your patients. So this is what we do.
Personable. If your post-meal blood sugar is more than 180 mg per dl, you need to add on 2 units of insulin. If
Neelesh, is this visible?
Is less than 120 mg per dl, that
yes, it's visible and audible both. Yeah.
Oh, perfect.
If, however, your blood sugar is between 120 and 180 mg per dl, that means that the dose given to you is correct and you don't need to either increase or decrease your dose. Also, please remember that if you check your sugars after your breakfast and suppose you need to increase the dose the next morning before your breakfast. Similarly, if your sugar is high either after lunch or after dinner, the dose of insulin that you have decided will be initiated the next day, either before lunch or before dinner. If, however, you have persistently high blood sugars, then you need to contact your doctor.
So I hope that was visible. How do I go back to my presentation? Oh yeah, I got that. Thanks. And we just made a very simple one for basal.
Starting dose of insulin, for example, say 10 units. You have to take the same 10 units of insulin for the next 3 nights.
So this is 2 resources which I can share with you at the end of the presentation.
At mealtime, carbohydrates in the food are broken down.
You'll have to go back and close those videos.
I'm sorry.
Body uses and stores for energy. Some foods
I think I opened some video which I can't stop. Oh yeah.
Than others. Your body uses blood glucose for energy. It's regulated by a hormone called insulin, produced in the pancreas.
Okay, where is this now? What did I do?
Go to the tab next to it.
Which causes blood sugar to soar.
blood sugar levels are too high. Insulin therapy वो डॉक्टर्स लिखा है टॉप पे ना मैम वो टैब पे उसके पास वाला टैब
nerve disease or
I am on that. Okay, I'll just stop my share. Just give me 1 second.
Yeah. Dialysis and the need for a transplant.
Oh God,
and
what did
finally,
I do?
Heart disease, which can cause circulatory.
Oh, okay. Thank you so much. So, is my slide visible?
No, you'll have to reshare.
Oh, do I need to reshare? Okay. Just give me a sec. So if you want, we can just share the links with you, and it's even available on Google. So you can just share it with your patient. So that would really, really help. Is this good, Neelesh?
Yeah, that is good. And I'll be sharing the links to these videos with everybody after this webinar. Yeah. I'll do the needful. Yeah.
No problem. Is my presentation visible?
Yeah, it is.
Okay. So technique is extremely important. Choosing the type of insulin and titrating the insulin is probably the bottom line. One of the other common mistakes that I see is the timing of insulin. Now, I'll tell you why this timing of insulin is incorrect most of the time, because a lot of time insulin is initiated in the hospital. And if you've ever been to a hospital where the sister is actually starting or injecting the insulin for the patient, the sister will wait till the food is served. It's there in front of the patient, and then the patient, the sister will inject the insulin and tell the patient to have the food immediately. So in hospital, the fear of hypoglycemia is so great that most of the time the sister will not give the insulin to the patient until the meal is served and delivered right in front of the patient. Because of this, when the patient goes home, he also somehow imbibes that mortal fear of hypoglycemia and takes the insulin and rushes to eat the food. So the basal insulin usually needs to be taken at the same time every day. Bolus insulin, if it's rapid acting, then needs to be taken at least 15 minutes before the food. If it's a regular insulin, it must be taken at least 30 minutes before the food. Similarly, if it's a premixed insulin, no matter which type it is, if it's a co-formulation, then 15 minutes before. And if it's a regular insulin premix, then it has to be taken 30 minutes before the meal. Dr. Kaushik, thank you for that question. That what is the distance which is required between basal and bolus? There is absolutely no distance required. So typically what we do is we give bolus about 15-20 minutes before each meal, and basal we want them to take it at bedtime. But it doesn't really matter what time the bolus is taken and what time the basal is taken. They both are independent of each other. And that is why if I take, suppose, a bolus at 8:30, I can take the basal if my basal time is 10:30. Now, some days I may eat my dinner at 9:30. Some days I may eat my dinner at even 10:30. The time of basal should not change. It should remain at the same time. The bolus time can be changed according to when the person is eating the food. And yes, Dr. Mulchandani, I've not attended carbohydrate counting because it's a little bit more complex. I always feel that even just getting these basics in place, 90% of the time you will not have any problem getting the HbA1c down. But in certain patients, we also need to educate them about carbohydrate counting, which could be the next step. Dr. Kaushik, yes, managing insulin of about 1 or 0.5 units is difficult. And for those people, definitely an insulin pump will be very important. And for most type 2 diabetes people, most of whom are not so brittle, our usual therapy is quite good. So the timing of insulin is very important. And after that, these two things, timely testing and tracking the trends. Now, timely testing means that most of the time patients say, I'm feeling low, I'm feeling low, I'm feeling low, and they'll eat. And actually, if they really check their sugars, they'll find that the sugar is high and it's not low. So testing is very important to find out that the symptoms are really hypoglycemia or not. A lot of hyperglycemia also can cause increased hunger. It's important to test at the correct time. For basal insulins, we target the pre-meals. For bolus insulin, we target the post-meals. For basal, bolus, or premix, we need to target both the pre as well as the post-meal. The frequency is very individual. For fasting blood sugar, and if it's only a basal insulin, then of course is the traditional 3 to 4 days would be reasonable. But depending upon how high the blood sugar is, how rapidly you need it to come down, what is the risk of hypoglycemia, how comfortable will it be for the patient to test so frequently, you will have to individualize depending upon the patient. What is more important is tracking the trend of the blood sugar. It gives accountability. People understand the effect of what they're eating. They can immediately see the results that when they take the insulin right and eat right, the sugar is good. When they don't take their insulin or they don't eat something which is correct, their blood sugars go up. So it's a very good teaching tool to keep people accountable, not only about their insulin doses, but the titration as well as the food that they are consuming. So these, I think, are probably the last T's. So storage and expiry, that all is technical stuff. I have just one interesting story, so I will never forget this lady. She still comes to me for follow-up. So this lady was initiated on basal insulin, and she was taking it properly. Everything was going well. Suddenly her blood sugar started trending upwards dramatically. So as we had taught her, she started titrating the insulin upwards and started taking pretty high doses of insulin. In spite of that, the blood sugar was not coming down. Then one fine day, she took the same dose that she was taking and she went completely unconscious, and the family found her at home unconscious. Now, what had happened is actually her insulin pen was not fitted properly. So she was taking the insulin, she was titrating it upwards, but actually the dose was not going. Now, one day her husband came, and without telling her, he looked at the insulin pen and he just fitted it properly. So unfortunately, what happened, she had increased the insulin a lot. And when that entire high dose of insulin actually went into her body, she just fell completely unconscious and she went into deep hypoglycemia. And that is why it's very important to check for pen malfunctions, in the middle, just to take 2 units, just squirt it, see if it's going properly, see if there's any airlock. It's important to keep looking at the insulin pen or the vials, see if there are any clumps, whether the insulin is clear or not. These small things are important. If the insulin has been frozen, it's been exposed to high temperatures like a car or something for a long time, it's probably not working as well. So all of these things put together, just ordinary, normal, regular insulin can help you to get the blood sugars controlled very well. Dr. Amir, we'll give you the link to the video at the end, and it's available on YouTube. Just type Dr. Tejal Lathia and insulin, and it's free to use. No, Dr. Lalit, if you take the dinner bolus and the bedtime within 1 hour, there will be no shoulder effect. You don't have to worry, because most of the time we're using ultra long acting or basal insulin. So it's not an issue at all. Sorry, Dr. Amir, we will send the video when possible. Dr. Neelesh, is there any problem with our audio? Because Dr. Amir is not able to hear very clearly.
No, ma'am. Your audio is perfectly clear to me.
Okay, sorry, Dr. Amir, maybe it's some issue with your thing. Okay, now this is the controversial part. I promise I will finish it in 10 minutes. It usually doesn't make me very popular with people. And thank you, Neelesh, for indulging me and letting me do this part. So this is something I feel very strongly about, is encouraging a different narrative about insulin. So this is from one of my favorite books I've ever read in my life. It's, I think, by Charlie Mackesy. I have the book right there. Asking for help isn't giving up. It's refusing to give up. So often when patients are started on insulin, they feel like they've given up and everything has failed and it's the end of the road for them. So often I encourage them by saying this, that using insulin to support your body, something that your body cannot make, is very, very important. And there is a doctor called Dr. Captain Chatterjee who lives close to my house, and he put it beautifully in one of the seminars that he was attending. He said, insulin आपके body की जरूरत है. लोग सोचते हैं कि आदत है, लेकिन वो आपके बॉडी की जरूरत है. So taking insulin is like asking for help and refusing to give up, not refusing the right to a healthy life, not refusing a poor quality of life, refusing complications. And this is what I tell my patients, that the greatest of all the freedoms that we have in our life is how we react to something. So I tell the patient this, that see, insulin is something that you need. You can choose how to feel about it. You can be angry, you can be upset, you can hate that insulin, you can be dissatisfied, and you can keep on grumbling and tell all and sundry how sad your life is because you need to take insulin. Or you can accept the fact that your body needs that little bit of extra help. You can make peace with it. You can accept that using this insulin is going to help you reduce the untoward effects of diabetes. It's going to help you have a good quality of life and help you to have continued good health. And when you put it like this straight up into the patient's face, that you can choose how to feel about it, it's something that they have never thought about in their life. It's something they just assume that when you start insulin therapy, it's the end of the road, and it's really a tragic thing to happen to them. So talking to them about how they can think about their insulin therapy, I think helps to a great deal. And telling them that we know that they're scared, but we can be less scared together, and having a trusting, collaborative relationship with their doctor, especially somebody like you who will empower them to manage their insulin therapy on their own as best possible, is the key to good health. Okay, sorry. Okay, now I also wanted to talk about these myths, and I will confess that I've been guilty about this. So, it's very common that we talk about busting myths and misconceptions of diabetes, and patients think rubbish, and doctor is right, and we will tell them how to think most of the time. So patient feels it's the end of my life. Now everything will be really bad. Insulin will damage my kidneys, and I will become addicted to insulin. So in these things, definitely this is a myth. It's not true that insulin means the end of life, or that insulin is harmful to the kidneys, or it is addictive. But there are certain other things that we call myths, that insulin is very painful. I can't live a normal life if I take insulin. लोग क्या कहेंगे कि मैं इंसुलिन लेता हूँ, और एक बार मैंने इंसुलिन शुरू किया तो मुझे हमेशा लेना पड़ेगा. Here I would beg to differ, and I think that whatever the patients are saying is valid. It is difficult to start insulin therapy. It really does affect the way you live our life. It may not dramatically affect, but yes, you do need to arrange your life a little bit more around the insulin. If you have taken a subcutaneous injection of any kind, even with the finest needle in the world, there is occasionally pain. There is occasionally blood which comes out. So what I'm trying to say is, maybe a couple of years ago, when a patient used to tell me that insulin therapy is painful, I say, of course it's not painful. What rubbish are you talking? We have such a fine needle now. It's very, very easy to take insulin, and it's not painful at all. But that is not the truth. It is occasionally painful. It is hard to start insulin therapy. And you need to change your mindset. You need to change the way you live your life. It does matter what your caregivers think about you. A lot of time you'll hear when somebody is taking insulin, the wife or the husband will comment every day, oh my God, you're taking insulin. Oh my God, you're taking insulin. How sad that you're taking insulin. A lot of times I have young kids that every time a relative comes into the house, the whole family in front of the child will discuss about the insulin that the child is taking and how sad it is. And yes, insulin, unfortunately, most of the time is going to be long term. So what I encourage you to do is, instead of invalidating what people are feeling, what you could say is, yes, I understand that insulin therapy is painful occasionally. We'll try our best by changing the needle regularly to minimize the pain as much as possible. But yes, it can be occasionally painful. I know that insulin therapy is hard. I know that it's difficult to take 2 shots a day and check sugars 4 times a day every week. I know that people sometimes make negative comments about insulin therapy, and I know it must be hard for you to listen to. I know it must be sometimes making you scared because you start worrying all over again whether this insulin is going to damage my kidneys. Yes, low sugar is a reality with any insulin therapy in the best hands in the world. There is a trade-off, and that trade-off is low blood sugar and weight gain. But we have to balance between the high blood sugar and the low blood sugar. And in the short term, low blood sugar is difficult. But in the long term, the glycemic benefit that you will have will keep you healthier for a longer period of time. So instead of invalidating what the person is feeling, acknowledging and accepting that insulin therapy that we are giving right now, including insulin pumps and CGM, is not perfect. We're trying to mimic the body as closely as possible, but we are still not yet there completely. Thank you so much.
Thank you, Dr. Tejal. It turned out to be exactly as I promised everyone. There's going to be a masterclass on insulin therapy and how to practically use it. So thanks a lot. And I would really like to thank the audience who are very active and in asking questions and participating in this webinar. I would invite anybody else who has a question to kindly go ahead, unmute themselves and ask a question. While they do that,
so
yes,
Dr. Kaushik was asking about insulin pumps. So, Dr. Kaushik, what I would like to say is that, people first need to master the subcutaneous insulin therapy first, because that itself takes a lot of training, and the pump therapy takes even more training, right? And it requires even more frequent testing. It requires a lot of care. So, in a way, insulin pump therapy is great. It can reduce glycemic variability, and Dr. Mulchandani is asking, it can cause much better time in range. It can cause better HbA1c, all of those things. But insulin pump therapy also is hard. So even in young children in whom we put them on pumps, we first start with subcutaneous insulin therapy. We get them used to carbohydrate counting. We get them used to testing regularly. And once they're comfortable with that, we start a trial of pump therapy. And I have a young patient, his name is Omkar, who was on subcutaneous insulin therapy. He was shifted to the insulin pump. Somehow he was not happy with the insulin pump, but he was a very smart kid. He went back to his subcutaneous insulin therapy, does beautiful carbohydrate counting, takes all his shots, and maintains his HbA1c very, very well. The insulin pump is not the answer to good knowledge, good technique, good timing, tracking, and testing. So it can be used, but again, with proper training and knowledge is what I would say.
Dr. Tejal, I had one question. So at Fitterfly, what we do is we marry CGM with structured lifestyle modification, and it's been used very widely in a lot of type 2 diabetes. Even you have referred a few cases.
Yes, yes.
And we have seen the outcomes that quite a few of those patients actually reduce the insulin, if not completely eliminated in type 2. What do you think about our programs and programs like ours? Do they actually help in reducing insulin requirement in type 2?
Yeah. So I think that using the CGM with your insulin therapy is a great teaching tool, first of all, because person can see directly the effect of the insulin injection, the food they're eating, and the blood sugar fluctuation, and that gives them a lot of information on how to manage the diabetes better. So it's a great teaching tool, number one. Second thing is, because at Fitterfly we balance the carbs, the protein, and the fiber. Because of the reduction in carbohydrate with a balanced diet, increase in protein and fiber, actually blood sugars get much, much better, and patients are able to manage the diabetes with lesser amounts of insulin. We also are able to help them reduce the frequency of hypoglycemia and minimize the weight gain which is associated with insulin. So that's very, very important. So CGM plus a structured program with insulin therapy usually works wonders. I have a young girl right now. Her name is Priya. I'll not say the full name. She's currently on the program. She's on multiple shots of insulin. And we started with a fasting blood sugar of 300 and a post-meal of 400. And they updated me yesterday. And now, like, maybe the fasting is 120, post-meals are 140, 150. There have been no hypoglycemias. The variability has come down. She's eating healthy. She hasn't gained much weight. And her insulin doses have remained stable or maybe come down by about 10 to 20%. So people on insulin therapy do especially well in the program because there's a lot of training, a lot of feedback, a lot of balancing out of the carb and protein. So I think it's very helpful. Especially adult insulin needing patients, they do very, very well.
So Dr. Mulchandani had a question on Fitterfly app. So Dr. Mulchandani, I'll get my team to call you to exactly explain it, because if I start explaining it, it's going to take a long time. But in short, it's an app and it's connected to a CGM device, and it's connected to a Bluetooth glucometer. It tracks your blood sugar and your diet, whatever you take, and depending on how your body reacts to various medications and how your body blood sugar trends are, we provide coaching via a nutritionist, a physiotherapist, and a psychologist to make sure that your blood sugars of your patients get under control. I'll give you a much more detailed explanation. We have your number. We'll get in touch with you, and I'll ask my team to give you a much more detailed application on how Fitterfly works.
Dr. Neelesh, can I answer Dr. Mulchandani's question very quickly? Dr. Mulchandani, I'll give you only 3 sentences. One is newly diagnosed diabetes. Doctor, mujhe goli nahi lena hai. You put them into the program because it makes them accountable, and not that they will come after 6 months ke maine exercise bhi nahi kiya, diet bhi nahi kiya, aur abhi sugar badh gaya, which is very common. Second is patient is on multiple oral hypoglycemic agents. You know this person needs insulin. You know they're not doing the lifestyle modifications fully. You put them on insulin. You put them on the program. They tidy up their lifestyle modification many times with the same amount of oral hypoglycemic agents. They're able to manage their blood sugars beautifully, and they're very grateful to you because they have been able to avoid insulin. The third category where people do really well on the Fitterfly app is somebody who's already on multiple doses of insulin, but still the blood sugars are not controlled. Because here the problem is not with the timing or the type of insulin. The main problem is with the insulin carbohydrate mismatch. So when they enter the program, as the carbohydrate is cut down, protein fiber is increased, their blood sugars come down beautifully, their hypoglycemia comes down, and the HbA1c also comes down. So if there are 3 areas where it's very helpful: newly diagnosed diabetes, multiple OHAs, needs insulin but not willing for it, already on insulin but still not able to manage their target blood sugar, then in that case, the Fitterfly app does really, really well.
Thank you for helping me out, Dr. Tejal. That was 3 beautifully shortened indications for our app. Perfectly listed out. So just one last chance if anybody has any more questions before I'll just close it up. Dr. Tejal, I guess you have a phone call, and we are already at the very close to the end of the webinar. So thanks a lot. I would like to thank all the audience for joining us, and thank you once again, Dr. Tejal, for such a wonderful webinar. Thank you. Thank you, everyone. Bye-bye. Thanks, Dr. Kaushik. I'll send you the video very soon.
Thank you, Dr.
Thank you, everyone.